I'm Dr. Cory Lappin, and I practice at Phoenix Eye Care and the Dry Eye Center of Arizona. And I'm excited to be lecturing for Eyes on 2023 today, and I will be talking about the best of both worlds, optimizing the ocular surface and eyelid health management. And I have no relevant financial disclosures. And before I go any further, I just want to dedicate this lecture to someone who is very close to me and many in the eye care community, Dr. Art Epstein. Sadly, we lost one of the true giants in optometry recently with his passing. And personally, I was fortunate enough to have the opportunity to work directly alongside him in our dry eye clinic the last several years. And to myself and many others, he was a mentor, a role model, most importantly, a friend, and we miss him already. And a lot of what I'm going to cover in this lecture today comes from the many conversations about dry eye and ocular surface disease that Dr. Epstein and I had over the years. So in many ways, this lecture is done in remembrance of him. So today's topic is optimizing the ocular surface. And this is a phrase that we throw around all the time, but what does it actually mean when we say we're going to optimize the ocular surface? Well, when we say we're going to optimize the ocular surface, what we are actually saying is that we are going to attempt to encourage or restore homeostasis. So going back to our high school or middle school biology classes, homeostasis is something we are all familiar with. And actually, the concept of homeostasis was first described by Dr. Walter Cannon in 1930 when he coined the term homeostasis by combining the Greek words homeos, meaning similar, and stasis, meaning standing still. This idea of homeostasis was such a revelation, it would go on to become the central unifying concept of physiology. So let's do a quick review of homeostasis before moving on to the ocular surface specifically. So the exact definition of homeostasis is a self-regulating process by which biological systems maintain stability while adjusting to changing external conditions. Or put simply, the body will try to keep physiological variables within a biologically predetermined range or set point, regardless of the outside environment. Now, the key part of this definition to emphasize is the body wants to stay within a range, not at a single value. This is why Dr. Cannon used the Greek word homeos, meaning similar, rather than homo, meaning the same, because the body does not stay at the exact same point, but rather within a similar range of values. And there's a reason for this. And that's because by operating with a range, it gives our body essentially some wiggle room, as it would be incredibly difficult to function if it had to stay at one exact point. However, once we deviate too far from this range, problems begin to occur and the system begins to fail. Now, this is what also gives us the concept of dynamic equilibrium, which is essentially a constant state of rebalancing. So to stay within a set range, a system will constantly change and adjust in response to the outside environment in an attempt to resist deviation from the set point. So you can kind of think of it like a set of scales, where one side is the biological system and the other side is environmental challenges. And the weight on the environmental side is constantly changing. So the biological system must constantly add or remove weight in response to try and keep the scales balanced. Because if the scales tip too far out of balance, homeostasis will fail and the system can no longer function properly. And the way the system knows, so to speak, what adjustments to make to maintain balance is based entirely on feedback provided to the system, making homeostasis a feedback-dependent process. This means the system requires various biological sensors to collect this feedback and send it back to higher processing centers. And this is where things get more complex, as an individual system, such as the ocular surface, is often integrated into several others to make one larger system. For instance, feedback received by the cornea when a foreign body gets in the eye is then sent back to the brain, and that sends a signal to the lacrimal gland and orbicularis oculi muscle to stimulate reflex tearing and blinking to remove the foreign body and restore homeostasis. And this whole process is carried out unconsciously, which underscores the self-regulated nature of the system. A classic physiological example of homeostasis is body temperature. We need to maintain our body temperature at around 98.6 degrees Fahrenheit to function properly, regardless of the external environment. So if we get too hot, we sweat to use evaporative cooling to reduce our body temperature. However, if we deviate too far from this set point of 98.6 degrees, usually at around 106 degrees or higher, homeostasis fails and we can develop heat stroke. Likewise, if we get too cold, we begin to shiver to try to generate body heat to warm us up. But if our body temperature dips too low, normally around 95 degrees, hypothermia can set in. Another common example of failure of homeostasis is diabetes. In diabetes, the body loses the ability to regulate blood sugar levels and keep them within a set range. And the way this happens almost illustrates a homeostatic arms race. So beta cells in the pancreas sense when blood sugar gets too high and then release insulin to increase cellular uptake of glucose to lower the levels of glucose in the blood. However, if blood glucose is chronically high, then insulin levels are also chronically high, and the insulin receptors on liver, fat, and muscle cells become desensitized to insulin and can no longer uptake glucose as efficiently, so blood sugar still stays high. And because the blood glucose is still high, the beta cells then produce even more insulin, but this just leads to further insulin resistance. And this cycle repeats until the beta cells eventually burn out and they stop secreting insulin properly, which leaves the body with an inability to regulate blood glucose levels, resulting in diabetes. So the way we attempt to treat this is by using exogenous insulin to try to restore the balance that the body is no longer able to maintain on its own. So this is the perfect example of a system that is constantly trying to maintain a balance between blood glucose and insulin production, but when the scales tip too far in one direction, the system begins to fail, and the result is pathology. So these examples of heat stroke, hypothermia, and diabetes highlight a key element of homeostasis, which is if a system cannot maintain balance, the result is disease or even death. So how does all this relate to the ocular surface? Well, the biggest disruptor of the ocular surface is dry eye disease, which we all know is by definition multifactorial. However, probably the most important part of the definition of dry eye is that it is characterized by a loss of homeostasis, which is elegantly stated in the DUES 2 definition of dry eye. So dry eye and ocular surface disease and all of their iterations and manifestations are fundamentally caused by a failure to maintain homeostasis. In fact, to truly understand dry eye and ocular surface disease, you must also understand homeostasis. And I absolutely love this quote by the physiologist George Billman, who basically says, if you do not understand the self-regulating process, meaning homeostasis, then it is not possible to comprehend fully the function of the body in health and in disease. And while that's a strong statement, I would definitely agree with that sentiment. So what does this mean in the context of treating ocular surface disease? Well, basically, it provides a framework for approaching ocular surface disease. So for the first step in optimizing the ocular surface, we must understand how it is meant to function in health. Then we must see what causes the ocular surface to lose homeostatic balance and what that loss of balance looks like clinically. And based upon this information, we can determine which treatment is the most appropriate to attempt to restore homeostasis. Now, remember, the ocular surface is more than just the cornea and conjunctiva. It is also comprised of the eyelids, eyelashes, tear film, meibomian glands, and lacrimal glands that all work together in tandem to provide a clear optical surface and protective barrier that allows our eyes to function. So to treat the ocular surface, you must address the function of each of these components. Now, there is a critical, almost philosophical concept to note before we go forward. When using the homeostatic perspective to inform our treatment philosophy, the goal of treatment should be based on addressing the root cause of homeostasis loss. That means we should focus on correcting the underlying cause of ocular surface disease rather than just masking symptoms. For instance, while you can get inflammation and MGD-associated dry eye, this inflammation is often a result or symptom of the condition rather than the root cause of MGD. So while steroids may be used in such cases, they are not addressing the underlying cause of the inflammation, so they are not fundamentally helping to restore homeostasis at a base level. So what happens when modern challenges are posed against a homeostatic system that was developed for a very different set of circumstances? Well, the result is a system that is constantly battling to maintain homeostasis in what can be a lopsided fight. And that's actually kind of what we have had happen in the case of dry eye disease. Essentially, our ocular surface developed for a vastly different set of purposes than how we use it today. Our ancestors were hunter-gatherers who primarily relied on their distance vision to spot predators, prey, and other food sources, with near vision being relatively less important. However, due to the relatively rapid rise of our emphasis on our near vision, brought on by the development of the printing press, the Industrial Revolution, rising literacy and education levels, and the ever-increasing presence of technology in our modern lives, a mismatch between evolutionary history and our modern environment has occurred. We went from being a species that primarily relied on our distance vision in the past to today, where the constant use of phones, tablets, and computers have moved most of our visual world within 3 feet. The problem here is that on the evolutionary timescale, this happened in the blink of an eye, pun only partially intended, occurring over hundreds of years versus millions. So we still have a visual system, an ocular surface that is predominantly adapted for distance vision, even though we spend the majority of our time focused on near objects in the modern world. And this puts tremendous strain on the system, as we are fundamentally using it in a very different way from how it developed. And the way we see this manifest clinically is the rapidly increasing rates of dry eye. So dry eye was once a condition typically associated with middle to late aged females, but now affects nearly every demographic, even teenagers and children. And a major driver of this change is our increased screen time, which has fundamentally changed the way we blink and use our eyes. So in many ways, dry eye as we know it today is a modern disease. So as previously mentioned, to understand how to optimize the ocular surface, we must understand how it is meant to function in health. So let's start with the tear film. Though we know this 3-layer model is an oversimplification of its structure, I really like to use this model purely from a conceptual standpoint, as it does a good job of illustrating the primary roles of each component of the tear film. So starting with the mucin layer, we essentially have the foundation of the tear film. Mucins are primarily produced by goblet cells, and the main function of the mucin layer is to adhere and anchor the primarily water-based tear film to the hydrophobic cornea. And it is also thought that they prevent adhesion of pathogens as well, so it has some protective function too. Next, we have the aqueous layer, which is produced by the main and accessory lacrimal glands. The aqueous layer is primarily composed of water and makes up the bulk of the tear film, but it is vital for lubrication, nourishment, and protection of the ocular surface, as it acts as a source of oxygen for the avascular cornea and flushes away any debris or microbes from the ocular surface. And finally, we have the lipid layer, which is a complex mixture of over 600 different lipid species and is produced by the meibomian glands. This is the outermost layer of the tear film and essentially acts as the roof, as it prevents evaporation and helps provide a smooth optical surface. And as I previously mentioned, homeostasis is a self-regulated system that is dependent on feedback, which allows it to respond to the external environment or challenges. And there must be sensors to collect this feedback. And one of these sensors for the ocular surface is the corneal nerves. The feedback they receive is responsible for monitoring and controlling normal epithelial cell turnover, wound healing, blinking and tearing, and providing sensation. The function of the corneal nerves are vital to ocular surface homeostasis, as is evidenced by the fact that the cornea is the most densely innervated structure in the body, with over 7,000 nerve endings per square millimeter. And it is likely that we're only scratching the surface of what these nerves are monitoring, given the abundance of nerve endings present. So knowing that we have different receptors for temperature, pressure, and pain, it's likely that some of these nerve endings are collecting information and sensing feedback on factors we are not even aware of yet. And while the cornea nerves act as sensors to collect information for the ocular surface, the lacrimal nerve carries out the response to this information as part of the parasympathetic nervous system. Like I mentioned earlier, if a foreign body gets in the eye, it is sensed by the corneal nerves, which sends this information back to the brain, which then sends a signal to the lacrimal gland to secrete tears to flush it away to protect the cornea. And this whole process is carried out unconsciously, so it's the perfect example of how the system is self-regulated, uses integrated feedback, and it allows the surface to be protected and maintain homeostasis. And it's likely that this integration also involves secretion of mucin and meibum, as the goblet cells of meibomian glands have been shown to have parasympathetic innervation as well. So what are some of the clinical signs of ocular surface homeostasis in action? Well, a common example we are all familiar with is epiphora. In cases of dry eye, especially evaporative dry eye, poor lipid production or even quality results in premature evaporation of the tear film. This in turn can cause irritation to the ocular surface, which is sensed by the corneal nerves. This feedback results in the production of reflex tears, which are a compensatory mechanism for this irritation, which is why our patients will often say that, no, I don't have dry eyes, my eyes water all the time. But we know that this is actually due to an overproduction of aqueous, which is the body's way of attempting to compensate for dryness. Another example you have likely encountered in patients are patients displaying excessive lipid production. And when you look at their tear film, it'll almost have like an oil slick-like appearance to it. And this can actually stem from cases of aqueous deficiency, as meibum production is increased in an attempt to compensate for a lack of aqueous production. And such compensatory action can also occur with the third major component of the tear film as well. While this image looks like different sized patches of SBK, the larger globs are actually mucus. And in person, this patient had an almost jelly-like consistency to their tear film. This is actually a relatively common finding in patients with significant meibomian loss, as the body ramps up mucus production in an attempt to stabilize the tear film. So you can often see a mucoid tear film in cases where lipid or aqueous components of the tear film are lacking, and the ocular surface has increased mucus production to try to compensate for this. This can basically be a sign of a last resort, as goblet cells and mucin dysfunction are rarely dysfunctional compared to MGD and aqueous deficiency. So the mucin layer can kind of be like the last man standing. So the body will use the mucin layer when the other components have failed. And then we can kind of use as an example filamentary keratitis, because that's a prime example of the ocular surface attempting to fix itself through feedback and self-regulation. So filamentary keratitis is thought to be caused by mechanical friction between the lids and ocular surface, often stemming from dryness. And then this friction leads to a buildup of degenerated epithelial cells, and these cells form a strand-like structure that exacerbates this friction as the lids blink over these dead cells, resulting in further irritation and inflammation. And the body responds to this inflammation and irritation by increasing mucus production, with the mucus then surrounding the epithelial cell core in an attempt to reduce friction between the lids and the degenerated cells. The result is an epithelial cell mucus complex that forms the filaments we see in filamentary keratitis. So this condition all stems from the ocular surface experiencing excessive friction, and then the body attempting to reduce this friction by increasing lubrication by producing more mucus. And then this leads us to the topic of inflammation. Inflammation often signals a failure of homeostasis. It is essentially the body's last line of protection. For instance, when the body experiences an acute injury or an infection, inflammation occurs as a way to protect the body. And now the damaging nature often associated with inflammation is due to the fact that the detrimental effects of inflammation often outweigh the benefits. However, in cases of chronic dysfunction, such as dry eye, where homeostasis can no longer be maintained, the body also can elicit inflammation as a last resort. In the context of dry eye, Dr. Epstein and I always like to think of inflammation in terms of primary and secondary inflammation. So in cases of primary inflammation, such as Sjogren's syndrome and autoimmune disease, inflammation is the root cause of the loss of homeostasis, where in cases of secondary inflammation, such as MGD, inflammation is the result of the loss of homeostasis. And the reason why we make this distinction is because it's helpful for determining the appropriate treatment. Because if you use an anti-inflammatory, like a topical steroid, to treat secondary inflammation, you're really just masking a symptom of the problem and not treating the problem itself. So now that we have covered the basics of homeostasis and a few clinical findings associated with homeostasis in action, let's take a look at the most common causes of dry eye and ocular surface disease through a homeostatic perspective. And now I've included a lot of information on these slides, but some of it will primarily just be for reference, as our main focus will be on how homeostasis is disrupted in each case and how we can attempt to restore it. So let's start with the most common contributor to dry eye, meibomian gland dysfunction. So in health, we produce high quality meibum that creates a smooth optical surface and prevents premature evaporation of the tear film. However, this function can be disrupted in several ways, resulting in many of the symptoms commonly associated with dry eye. Now, when I was mentioning the evolutionary mismatch between how the ocular surface has developed to function and how we use our eyes in modern life, the meibomian glands and lipid layer take the biggest hit. And the reason for this is that the function of the meibomian glands and meibum are intrinsically tied to factors like blinking behavior and diet. So the first challenge posed by our modern lifestyle is our diet. Our ancestors had a diet that was high in omega-3s. However, the modern Western diet is deficient in these fatty acids. This is an issue because omega-3 fatty acids are one of the key building blocks of healthy meibum. So if our diet lacks omega-3s, our body will still produce meibum, but it will be of a poor quality. And the second challenge posed by our modern lifestyle is excessive screen time. As I discussed, our ancestors primarily used their eyes for distance-oriented tasks, such as hunting, while many of us spend the majority of our time staring at a screen for both work and leisure. The issue arising from this change in behavior is that it fundamentally alters the way we blink. So when we look off into the distance, we blink around 16 to 18 times per minute. But when we look at something up close, that can drop to 4 or less times. And this is because our brain deems anything that we are looking at up close as important information. Otherwise, why would we be examining it so closely? So in response, our blink rates drop as it would be hard to get a sustained view of a near object if we were constantly blinking. Now, this would not be much of an issue if we were examining objects up close only periodically, which is more in line with how our ancestors used their near vision. However, we now maintain sustained near visual focus for durations far exceeding anything our ancestors would have ever done. For instance, hunter-gatherers may have closely inspected berries on a bush or animal tracks on the ground for brief periods of time, but this is vastly different from the hours we spend working on a computer or scrolling on our phone. And because we are spending so much time focused on near tasks, our bodies run into the issue where we want to blink, but we also do not want to obstruct our vision with constant blinking. So what happens is we begin to perform partial or incomplete blinks. And this reduction in blink rate and use of partial blinks has a profound effect on the ocular surface for two reasons. First, the ocular surface dries out because we are not replenishing the tear film as often, which can cause blurred vision. And second, and more importantly, it alters meibum secretion. The meibomian gland orifices are surrounded by the muscle of rheolin, which is thought to help control the amount of lipid that is excreted with each blink. And additionally, it is believed that with each blink, the meibomian glands are pressurized. So when we blink and the lids completely touch, the muscles of rheolin relax, opening the ducts, and the pressure from the blink pushes the oil out onto the lid margin, and it is then spread over the ocular surface. However, when we partially blink, the lids do not completely touch. So the muscles of rheolin do not relax, and the oil builds up and builds up, but the meibum is never secreted, which can result in a low lipid level in the tear film, which can lead to premature evaporation, which manifests clinically as a decreased tear breakup time. And the failure to release meibum properly can cause the glands to become distended and inspissated as the meibum backs up and gets clogged. Now, this clogging combined with a diet poor in omega-3s can result in that thick toothpaste-like meibum we see in MGD, as opposed to the olive oil-like consistency we see in health. And over time, this chronic obstruction can result in inflammation of the glands, which leads to gland loss and worsening lipid production. So things like meibography are critical tests in determining the severity of a patient's MGD, as you can directly visualize the extent of their gland loss. So in this image, you can see the results of this gland dysfunction in a patient displaying significant gland loss along with gland devitalization in the presence of ghost glands. So how do we attempt to restore homeostasis in cases of MGD? Well, we go back to the root causes by addressing diet with omega-3 supplementation and poor blinking mechanics with blink exercises. And we can also use lipid-based artificial tears and warm compresses. However, these are primarily for providing comfort rather than treating the causes of MGD. Additionally, we can attempt to clear any clogged glands with thermal pulsation procedures, or we can use IPL to try to stimulate the function of the meibomian glands. And although it's routinely discussed, true cases of aqueous deficiency are relatively uncommon. So in the majority of cases, patients do not exhibit any issues with the aqueous layer, and the surface of the eye is properly lubricated and debris and potential pathogens are flushed away. However, in cases such as Sjogren's syndrome and other autoimmune diseases, inflammation damages the lacrimal gland, which disrupts aqueous production. And this leads to a poor corneal hydration and increased surface damage and the risk of infection as microbes and foreign bodies are not effectively removed. And these patients will typically display significant SBK and ocular surface irregularity, like you can see in this picture. Now, as inflammation is often the primary driver in many cases of aqueous deficiency, the use of anti-inflammatory treatment is often necessary to address the root cause. Now, topical steroids can be used for short durations to manage acute flares, but long-term use is discouraged because it carries the risk of increasing IOP, which can lead to glaucoma and also causing premature cataracts. So immunomodulators like Xiidra, Cequa, and Rosacea are better suited for long-term inflammation management. Additionally, neurostimulatory treatments such as Tyrvaya or the iTear 100 device can help promote tear production. And again, artificial tears can be used as a palliative treatment. Another class of treatment that can be helpful in these cases is regenerative or biologic-based treatment, such as amniotic membranes or autologous serum, which both carry anti-inflammatory and restorative effects. And as far as in-office procedures go, IPL can be helpful as it has been shown to decrease the level of inflammatory factors present on the ocular surface and in the tear film. And in recalcitrant cases of aqueous deficiency, scleral lenses can be used to essentially create an artificial barrier environment by constantly keeping the cornea bathed in fluid. An often overlooked cause of ocular surface disease is nerve dysfunction, despite the fact that the nerves probably play one of the biggest roles in maintaining ocular surface homeostasis. as the corneal nerves are responsible for controlling routine epithelial cell turnover, wound healing, blinking, and tearing, and providing sensation. So if there is damage to the corneal nerves directly or at any point along the trigeminal pathway, these functions are disrupted, ultimately leading to a breakdown of the ocular surface as the epithelium is no longer regularly replenished, wound healing is impaired, and proper blinking and tearing is disrupted, and corneal sensation is lost. Clinically, this manifests as neurotrophic keratitis. Some of the most common causes of nerve dysfunction are herpetic infections, as the virus lays dormant in the nerve ganglia, and refractive surgery such as LASIK, which involves severing the corneal nerves during flap creation. And this picture here is from one of our patients who underwent gamma knife surgery to treat her trigeminal neuralgia, which unfortunately ended up damaging the nerve and resulted in neurotrophic keratitis. And you can see she displays the classic neurotrophic ulcer with smooth rolled edges. But she had relatively little associated pain, which is the hallmark finding of neurotrophic keratitis and nerve damage, as the nerve damage has resulted in a loss of corneal sensation. Thankfully, we have made great strides in the treatment of nerve damage and dysfunction, which is fortunate given how potentially devastating nerve damage is to ocular surface homeostasis. Treatments such as amniotic membranes and surgical procedures like tarsorrhaphy can help stabilize the surface, but they do not necessarily address the underlying cause. However, this is what sets oxervate apart from other nerve treatments. So oxervate is a recombinant form of human nerve growth factor, so it directly repairs damaged nerves. So this makes it an excellent homeostatic treatment as it directly addresses the root cause of homeostasis loss. And this picture is actually from the same patient I showed previously after being treated with oxervate. So you can see the huge difference that it makes. Another easily overlooked but common disruption to the ocular surface stems from mechanical eyelid issues. In health, our eyelids close completely with each blink, which allows for tear film to be replenished and spread over the ocular surface. And at night, the lids completely close, creating a tight seal that protects the ocular surface while we sleep. However, for many of our patients, this is not the case. The classic signs and symptoms of incomplete lid closure are dryness that is worse in the morning and inferior SPK, which corresponds to corneal exposure, which you can clearly see in this photo. And while most people would expect exposure in cases of obvious ectropion or Bell's palsy, it is actually quite common among older patients in general. And this is because we naturally lose lid elasticity with age. And in some cases, there will be no obvious gap between the lids, but rather a poor lid seal where even though the lids touch, the upper lid tends to just rest on the bottom lid instead of forming a tight seal, which can result in the same issues. And nocturnal exposure can be particularly disruptive because our body primarily repairs itself during sleep. So in patients with exposure, their eyes are being damaged during the very time when they are supposed to be being repaired. Additionally, these patients essentially start the day behind the 8 ball, as most dry eye patients experience a worsening of symptoms as the day progresses. But these patients already wake up with dryness and surface irritation, so it's likely only to worsen as the day progresses. However, in cases of exposure, we are often left with compensatory rather than homeostatic treatments, as one of the few options that can actually change lid position is surgery, which should be approached with caution as it can actually worsen exposure if lid position ends up overcorrected after surgery. Some good starting options are the use of gels or ointments to use before bed because they're thicker and can help the eyes stay lubricated and protected throughout the night. If patients can wear them through the night, moisture goggles can be extremely beneficial as they create an enclosed environment. And the use of contact lenses can also be beneficial, including scleral lenses and soft BCLs for cases of persistent lagophthalmos. Now, bacteria and mites are another lid-related concern that can disrupt the ocular surface. We all naturally have bacteria that live on our skin, and the same is true of Demodex mites, and this is completely normal. However, if these bacteria or mites overpopulate, then it can result in a disruption of the ocular surface, usually in the form of blepharitis. In cases of Demodex, the mites reside in the lash follicles and meibomian glands, which can result in blocked glands causing MGD. And there's often a buildup of pro-inflammatory sleeve-like collarettes on the bases of the lashes, which consist of debris, Demodex eggs, and waste. And this picture shows an example of these lash collarettes, which are pathognomonic for the presence of Demodex. So if you see them, you should keep Demodex in mind as a potential contributor to your patient's dry eye. And in cases of bacterial blepharitis, especially involving staph species, the bacteria produces lipases that break down the lipid component of the tear film, which causes tear film dysfunction. This can be seen clinically as saponification or frothy or foamy tears. Bacteria also release pro-inflammatory exotoxins, which can further exacerbate dry eye. And chronic inflammation caused by either bacteria or Demodex can cause eyelash loss or scarring of the lid margin that gives it that notched or scalloped appearance. And this scarring itself can interfere with proper lid function, contributing to the vicious cycle of one condition exacerbating another, often present in dry eye. And just like with collarettes and Demodex, if you see foamy or frothy appearance to the tears, like in this picture, you should have a high suspicion of bacterial overgrowth contributing to tear film dysfunction. So the way we attempt to restore homeostasis in these cases is by getting the bacterial and mite populations back under control. And this basically involves lid hygiene. So hypochlorous acid is an excellent choice for bacterial blepharitis, as hypochlorous acid is what our body's own immune cells use to kill bacteria. Whereas tea tree oil and okra-based cleansers can be used to eliminate Demodex mites. And soon we may have the first FDA-approved treatment for Demodex in the form of lotilaner solution, which effectively paralyzes the mites and reduces the number of pro-inflammatory collarettes present. And manual debridement procedures such as new lids and Blephx can be helpful in removing bacteria and Demodex, as they often have associated debris, collarettes, or biofilm that is present on the lid margin or lashes. And IPL is another good option, as it has been shown to reduce the presence of both Demodex and bacteria. Keeping with the theme of common but often overlooked conditions that interfere with ocular surface homeostasis is ocular rosacea. Ocular rosacea is thought to be an exaggerated response of our innate immune system, and in health, the antimicrobial peptide cathelicidin is produced when a potential pathogen is encountered. However, in cases of ocular rosacea, it is produced in response to normal environmental stimuli like cold weather or spicy food. And this is an issue because cathelicidin stimulates production of VEGF. And this increase in VEGF results in the development of pro-inflammatory spider-like telangiectatic vessels found on the lids and lid margin that are characteristic of ocular rosacea. And these abnormal vessels are often perpetually dilated and prone to flushing with certain triggers like alcohol consumption. And all of these factors can create significant cosmetic redness, which is a major aesthetic concern for many of our patients. And these vessels also secrete pro-inflammatory factors that inflame the adjacent meibomian glands, leading to MGD. This picture is one of our ocular rosacea patients and is a great example, as you can see the dilated spider-like vessels and the inflamed meibomian glands next to them. While there's no cure for ocular rosacea, the best way to reduce its impact is to decrease its associated inflammation through avoiding triggers that can cause rosacea flares and the use of anti-inflammatory treatments such as low-dose doxycycline or immunomodulators. While not necessarily a homeostatic, Lumify can help provide cosmetic redness relief by constricting the telangiectatic blood vessels. Additionally, Lumify does not cause rebound redness that we typically associate with Visine, so it's a good option to discuss with patients when cosmetic redness is a concern. However, perhaps the best treatment option for ocular rosacea is IPL. And this is because it can be used to destroy the telangiectatic vessels that are responsible for the inflammation associated with ocular rosacea, as this is closer to addressing the root cause of the condition. And then allergies and hypersensitivities are another common source of ocular surface disruption. And this disruption to homeostasis in these cases is similar to ocular rosacea, as they are the result of an abnormal or exaggerated response to normal stimuli. In fact, it is thought that the allergic reaction is an abnormal activation of the immune response that developed to target parasites such as parasitic worms, but now is triggered by allergens such as pollen. And this response can result in significant inflammation. And then in cases of chronic allergies or hypersensitivities such as AKC or VKC, inflammation can be a major factor. So one of the best ways to restore balance in these cases is to block the response at its source. For allergic reactions, antihistamine and mast cell stabilizer combos are an excellent choice, as they block the effects of histamine, which has already been released, while preventing further degranulation from mast cells. Other hypersensitivity reactions like AKC and VKC can be more challenging, as the use of steroids will often be necessary to control acute exacerbations. And then immunomodulators such as Rosacea, which recently received FDA approval for the treatment of VKC, can be used for long-term inflammation management. And while bacteria, mites, and overactive immune responses are obvious disruptors of homeostasis, sometimes an equally troublesome challenge is the environment itself. Some climates are naturally more challenging to maintain homeostasis in than others. For instance, our practice in Phoenix is in one of the hottest and driest environments in the country. But many of our patients are snowbirds who spend their summers in the Midwest or East Coast, where the climate is cooler and more humid. And when they return to the desert here in Phoenix, they tell us that their eyes feel much drier than when they were in one of these more mild environments. And I can personally tell a huge difference myself in how my eyes feel in Phoenix compared to when I visit my family back in Ohio. But it's not just outdoor environments that can put stress on the ocular surface. Air conditioning, ceiling fans, and furnaces all create a desiccating stress that makes it difficult to maintain tear film and ocular surface stability. However, this is one instance where sticking to a purely homeostatic approach is probably not the best idea, as I would not recommend telling a patient that the only way to fix their dry eye is to move. However, I've actually had several patients tell me that that is exactly what their previous doctors told them. So I'd say a better approach is by trying to protect the ocular surface from the stress of the outside environment by using things like moisture goggles, shielded specs, or scleral lenses. It may also be helpful to use a humidifier in drier climates, or in the winter months of colder areas where furnaces can dry out the air inside. Additionally, tuning up the tear film by addressing other contributing factors such as MGD can help make the ocular surface more resilient and able to withstand the challenges posed by more demanding climates. And then there's the disruption to homeostasis that we are directly responsible for, which is contact lenses. So by their very nature, contact lenses disrupt homeostasis because we are introducing a foreign body onto the ocular surface. And it has even been suggested that contact lens wear in general is inherently pro-inflammatory for this reason. So the goal of contact lens use should be to minimize the disruption to homeostasis. And some of the best ways to do so are using daily disposable lenses, which lessens the buildup of protein or debris on the lens surface, and to use lens materials that more closely mimic or have good compatibility with the tear film and ocular surface. Additionally, avoiding any overwear is key, as miswear is the root cause of many contact lens related issues. And then in this next section, I just want to discuss some treatments of note and where they fit into the context of ocular surface homeostasis. And the first treatment I want to mention is IPL. You may have noticed, and it was listed as a treatment option for many of the conditions discussed. And the reason for this is because IPL is particularly effective treatment option because it addresses several of the root causes of ocular surface disease in a single treatment modality. For instance, it treats MGD by improving meibomian gland structure and function and improves meibum quality. It has also been shown to decrease the levels of ocular surface inflammation and inflammatory factors found in the tear film. And it destroys the pro-inflammatory telangiectatic blood vessels associated with ocular rosacea. And it can also reduce the number of bacteria and Demodex mites present. Also, it may help improve blinking mechanics by increasing lid skin tone due to an increase in collagen synthesis. So all these benefits make IPL an excellent homeostatic treatment choice, as it essentially tunes up several components of the ocular surface at once. Thermal pulsation devices have a bit more focused, but still very effective purpose. As these treatments heat and clear the meibomian glands of clogged oil, they do more than merely remove obstruction. By emptying the glands, they basically reset the system, and this signals the glands to start producing new meibum. This reset function likely produces a more profound effect than simply clearing obstruction alone. And this could also explain why, in many cases, the effects of thermal pulsation treatment can be long-lasting, even lasting for years. And microblepharal exfoliation can be a key to optimizing the health of the eyelids. The presence of microbes like staph bacteria and Demodex, like I previously mentioned, can create pro-inflammatory biofilms and collarettes, in addition to the damage they directly inflict, such as impeding meibum secretion by blocking the meibomian glands and stimulating inflammation that can damage the lids and lashes themselves. So the use of Blefex or new lids can go a long way in restoring homeostasis by removing these problematic microbes and their associated debris. Now, some of you may have noted that I did not previously mention punctal plugs as a treatment option, and there's a few reasons for this. The first is that the concept behind punctal plugs is based on an antiquated understanding of dry eye, which is based on the idea that dry eyes literally are caused by a lack of moisture. But we know that this is not really the case for the vast majority of patients. Rather, dry eye is often the result of poor quality of tears rather than a lack of quantity of tears. So in the majority of cases, the use of punctal plugs doesn't really make sense. Additionally, the use of punctal plugs risks creating a cesspool effect. Dry eye patients have been shown to have elevated levels of inflammatory factors in their tears. So by placing punctal plugs, this is essentially causing poor quality pro-inflammatory tears to sit on the surface longer, which can actually exacerbate a patient's dry eye. It basically would be similar to plugging up the drain of a bathtub, which is full of dirty water. And we also know that aqueous deficient dry eye is typically associated with inflammation. So even in cases where tear production is reduced, you still run the risk of worsening inflammation by keeping the tears on the surface for a longer duration. Also, plugs are inherently non-homeostatic, as they do not address the underlying cause of dry eye, but they're really just trying to mask the symptoms by increasing tear volume, basically acting as an extended artificial tear. And also, we have puncta for a reason. as the tears are supposed to drain and remove microbes and debris from the ocular surface. So by plugging them up, it fundamentally disrupts homeostasis. This is why epiphora occurs in many patients with plugs, as we are altering the patient's homeostatic balance. And this is why some patients experience initial relief when plugs are placed that diminishes with time, as the body actually adjusts and adapts to its new homeostatic set point. And this picture is actually one of our patients who was experiencing chronic redness, burning, and epiphora that improved once we removed their plugs that had been placed previously. So sometimes it can be just as beneficial to remove plugs as it is to place them, especially in cases of dry eye where there is significant inflammation. However, there can be cases where the use of plugs may be warranted. And in these cases, I would recommend the use of a dissolvable collagen plug first to see if it provides any substantial improvement before inserting a semi-permanent plug. However, I never recommend punctal cautery, as this is irreversible without further surgical intervention, which is likely only to exacerbate a patient's ocular surface disease. The use of therapeutic contact lenses can be incredibly helpful in cases of severe ocular surface disease. However, we kind of review them as a last line of treatment. And this is because they do not restore homeostasis, but rather create a new homeostatic environment, as we are essentially closing off the ocular surface from the external environment, rather than attempting to restore the function of the ocular surface in its natural environment. And this is also the reason why scleral lenses are not a cure-all for dry eye, because they are not necessarily addressing the underlying causes of dry eye, such as MGD or inflammation associated with Sjogren's syndrome. And then we have the most common dry eye treatment of all, artificial tears. What is often overlooked in artificial tear use is that they are really not therapeutic as much as palliative, especially from a homeostatic perspective. This is why I often call them a Band-Aid in a bottle, as they mask symptoms for a few minutes, but the symptoms usually rapidly return because they do not address the underlying cause of dry eye. Now, this doesn't mean that artificial tears can't be helpful. It just means they should not be used as the sole treatment in the vast majority of dry eye cases. And the final group of treatments I want to discuss are regenerative treatments. And this is an area of extreme interest in the field of ocular surface disease, as they are intrinsically homeostatic, as the goal of regenerative medicine is to address pathology at its root cause and restore function. As I previously mentioned, oxervate is a recombinant form of human nerve growth factor, which repairs the nerves in neurotrophic keratitis, which is the root cause of that disease. And amniotic membranes like Procara contain powerful anti-inflammatory and growth factors that are capable of healing even the most damaging ocular surface pathologies, such as corneal ulcers or chemical burns, which makes them an excellent choice for ocular surface disease, displaying significant corneal surface disruption or inflammation. Now, a specific treatment I wanted to address is Regenerative. And the reason for this is because this drop has become incredibly controversial. And the primary reason for this controversy is based around the drop's stated use of anti-inflammatory and regenerative cytokines, chemokines, and growth factors. However, as the actual formulation is proprietary and had not undergone FDA evaluation, this had provoked some skepticism from some initially. However, it's worth noting that the active ingredient listed for Regenerative is glycerin, while other factors listed are inactive ingredients. And with all that being said, I can say, at least from personal experience, we have used Regenerative with significant success in our clinic, and the only side effect we've noted is transient burning in a small number of patients, which is not unlike that experience with immunomodulators. So my advice for those who are considering using the drop but are unsure would be to just use your best clinical judgment and discuss its use with your patient, and then make the best choice you feel, is best based on that conversation. So I know we covered a ton of material in this lecture, and there is much more that we could discuss. But the biggest takeaway is, if your goal is to optimize the ocular surface, then what you are essentially trying to do is encourage proper homeostatic function. And to do so requires knowledge of how the ocular surface is supposed to work in health, what factors can disrupt this function, and what this disruption looks like clinically. And based on this knowledge, you can determine the treatment that will best help restore homeostatic function. And while this treatment approach can be used to treat nearly any pathology, it is especially helpful in the context of multifactorial conditions like dry eye and ocular surface disease, as it will help you uncover the root cause of the disorder and allow you to treat the condition at its source. And by treating the underlying cause, you will restore proper homeostatic function and will have successfully optimized the ocular surface. And here are my references for anyone interested. And that wraps things up. So I want to thank you all for listening, and I hope you enjoy the rest of the conference.
All right, everybody. Thank you, Dr. Cory Lappin, for giving an amazing lecture, talking about the two worlds here that were merging as he went through his content in for the ocular surface and eyelid health. I'll keep this one short and sweet. The code is IVT, intravitreal treatment. IVT.